you are.
I'm ready. Good
Okay.
evening, everybody. Welcome to our Wednesday webinar series. We are very, very lucky tonight to have one of our wonderful epileptologists, Dr. Milena Pavlova. She is, and I'm going to give you a little bit of information about her. She's from Brigham and Women's Hospital, and she is the medical director of the Sleep Testing Center. She has special interests in sleep medicine and epilepsy. She actually is going to be speaking tonight a lot too about the circadian rhythm and the effects on that on epilepsy. She also has an interest in the role of sleep and biological rhythms and pathogenesis of sudden death in epilepsy patients, which is SUDEP. Her medical education, she did her internship at Nassau County Medical Center, and she also did her medical school at Sofia, Bulgaria, and her residency was at Yale University, and her fellowship was at Brigham and Women's Hospital. And we are so happy to have her tonight. Thank you, Dr. Pavlova, for volunteering your time with us tonight. And I want to remind the participants about that all of our speakers that we have every Wednesday have graciously volunteered their time to be with us every Wednesday at 7 o'clock. So Dr. Pavlova, I am going to pass the mic to you. I do want to remind our participants that if you have questions, please put them in the chat box. And at certain times, Dr. Pavlova will pause and ask questions. We'll also have time at the end for questions as well. You're also welcome to unmute yourself, raise your hand, use your little raise your hand button at the bottom, and more than welcome to unmute yourself and ask those questions during those question time. So I am going to pass the mic. Thank you so much, Dr. Pavlova.
Thank you very much for your very kind introduction. I'm flattered to be here and really grateful of the opportunity to be helpful to you as much as I can. And I'm used to being interrupted, although it's not very easy to do that actually on Zoom. But the field of sleep and epilepsy is actually fairly exciting, but also fairly large. I cannot cover all the topics within a small period of time. And since the interactions are very complex, and the field of sleep disorders is just a one-year training, it's something that we can explore in more detail at another time, but I will focus on something that is relatively less addressed in most sleep clinics, which is the circadian rhythms. And I'll start with a case. This is actually a real case. I've obviously removed identifying details, but roughly this patient was 23 at the time when he saw me. He had seizures since the age of 17, but he was well controlled. He was taking his medications very regularly and consistently, and his seizures were controlled. He had no seizures that he knew of within the past 2 years before seeing me. He was in college, and as a college man, he was fairly consistent with his sleep times, but they were between 1 in the morning and 9 in the morning, so allotting a good 8 hours for sleep. And he was finishing college and basically entering nursing program. And so his questions to me was how to best handle the shifts. And one of them was obviously the likely night shift, but also the fact that if you have to be in the hospital before 7 in the morning, you have to, consider time for commuting and so forth. So he was wondering, since his usual wake time was 9 in the morning, how is he going to be handling this and how to best handle, and if it's even safe for him. although he was very determined, obviously already enrolled in the nursing program. And so in that connection, I wanted to raise the issue with you that sleep is often considered in isolation and something that our society has been more and more training us to consider as somewhat of a luxury, sleep when you can. Um, but in reality, we need sleep. Every species that have been tested actually for the presence of sleep, sleep somehow. Um, and the timing of that sleep has been more or less adjusted to the fact that the Earth rotates and we have dark and light periods. And species that use their that are diurnal, like humans, sleep during the night. And in relation to this, we have biological rhythms that allow us to do this. And we certainly can sleep during the daytime, um, but the duration and the structure of that sleep actually changes. And this is a complex looking graph, but I'm going to simply explain it. This is a seminal paper from the 80s that established the biology of sleep and wakefulness and how these are determined by our biological uh, timing. Um, and um, and they determined the biological timing. They assigned phase 0 at the time when the body temperature is minimal. And so what they determined is that um, we sleep mostly around that time, around our biological minimum. And then the structure of that sleep favors a specific distribution of the different sleep stages based on when we sleep. If we try to sleep during the daytime, it's a little harder. And in fact, if we try to sleep, particularly in the afternoon, late afternoon hours, around like 6 p.m. or so, for someone who is well established nighttime sleeper, it is particularly difficult. They call it the wake maintenance zone or the forbidden zone for sleep. So the late afternoon is kind of the least likely for someone to fall asleep, if provided all other things are equal. Um, and um, and this is something that is not set in stone. Our brain is not a stone. It is a dynamic and very responsive and very smart organ. And the period of the regularity of these biological rhythms is not precisely 24 hours. It's in some people it's a little bit shorter, in some people it's a little longer. So it gets reset on a daily basis, actually, by the effect of light. There is a direct pathway from our eye to the to our brain, to a specific center in our brain that acts a bit like a master clock. Um, and and regulates sleep and wakefulness, but also regulates a number of other body functions. For example, if you measure heart rate as well as blood pressure, all of these things actually have diurnal variations, as well as many hormones. In fact, during our biological night, we actually secrete melatonin from our pineal gland, and this is one of the markers that we use when determining when is the biological night in an individual. Um, and why am I telling you this? Because a lot of a lot of people have difficulty sleeping. In the general population, at least 1/3 of the people have reported difficulty sleeping. But among the epilepsy patients, this number is much higher. And this is one study where they looked at 90 adults, and 60 of them, almost 60 of them, had insomnia complaints, meaning they cannot sleep well. There was a high correlation with depression, and also some other things that have to do with more head trauma, asthma, as well as other diseases that affect breathing. And needless to say, many of these people used medications to help them sleep. Another study looked at 152 patients, and again, more than half reported um, clinical symptoms of insomnia. Um, but more than 70% were saying that they're not good sleepers. And that correlated with poor quality of life, but also predicted that these patients would have a higher number of uh, seizures as well as number of medications for seizure control. Um, Yet another study, again, this is with 200 patients, almost half of them clinically significant insomnia, um, and and about half had at least mild insomnia. Um, Similarly, higher severity of the sleep symptoms correlated strongly with quality of life, and significantly worse in those who had more frequent seizures. Needless to say, they looked at many other variables, but specifically they looked at depression, as well as other comorbidities which were higher in those who had sleep complaints. Now, seizures also affect sleep. And this is, again, this is a bit of a dated graph, but it can no longer be obtained. So I'm showing it. This was from 1996, and they tested the same patient with a sleep study before and after treatment with a medication for the epilepsy. Excuse me, I think, yeah. So the top part is something called a hypnogram uh, before starting the medication, and the second one is the same hypnogram after starting the medication. And to orient you, W stands for wakefulness. So when you see the line being here in wakefulness, that means that the patient has woken up. And then there are different sleep stages. And the arrows indicate each seizure. So this is someone who had actually multiple seizures during the night. So you see each arrow, most of the arrows have provoked an awakenings. The very same patient was tested after being treated with carbamazepine, in this case, anti-seizure medication. The seizure medication works. There are no seizures and only 2 awakenings throughout the whole night. The reason why you can't see it nowadays is that it's much more difficult to obtain a polysomnogram on a patient. And nighttime seizures may be particularly may have their own set of danger for the patients, because uh, yes, it's true that the patient is in bed. It's not as easy to get injured from a fall, and they're certainly not driving. But it seems that physiologically these things are fairly dangerous, because we looked at seizures that occur from sleep versus seizures that occur from wakefulness, and it turns out that those that occurred from sleep led to lower amount of oxygen in the blood, and longer time to recover from that lower amount of oxygen in the blood. So this is the maximal amount of oxygen in seizures from wakefulness versus seizures from sleep. And then the minimal was significantly lower, and then the drop was significantly lower in seizures that occurred from sleep versus seizures from wakefulness. So in summary, more than half of the patients with epilepsy do report difficulty sleeping, and many of them would be diagnosed fit the diagnostic criteria for insomnia. Um, and there is bidirectional relationship between seizure frequency and sleep loss. But the time of sleep opportunity also matters, and the biological rhythms may affect many body functions, including sleep, but also other body functions, and are actually independent from the state of sleep and wakefulness. And at this point, I can actually make a small pause and take a few questions about physiology, if there are any. If there are, I see three things in the chat.
Second, there is one question that
Uh,
just came through. It says, why does my toddler get seizures at night only?
oh, that's $1 million question. But yes, so there are specific forms of epilepsy that are predominantly at night. And so I don't know if this is one of those forms of epilepsy, but it's some of these epilepsies are actually benign. Some of them are not so benign. Um, but it depends on the form of epilepsy. There are specific locations of the seizures that are predominantly from sleep, or sometimes exclusively from sleep. Specific epilepsy syndromes that are specific for sleep. Um, one of them is one is the so-called benign epilepsy with centrotemporal spikes. I don't know if this is or Rolandic epilepsy. Is this what your child has,
Yeah,
or is it?
that was my question. My child has cerebral palsy, so he
Ah,
does have that brain injury, but it's so bizarre. Yeah, his seizures have been only at night or like right upon waking at like 5 a.m. in the
hmm,
morning, and we get
yeah,
notified by like a pulse ox basically. And so I just think it's interesting, and I just don't know much about it, which is why I'm here.
yeah. Uh, we don't know. We just have observed that there are specific syndromes that occur at night. And usually it's the frontal lobe that's involved, so probably the location of where the seizures are coming from matters, but there are also specific genetic associations. Um, so there is a benign occipital epilepsy. There are various genetic associations. With cerebral palsy, my best guess would be because the location is such that favors predominantly nocturnal seizures. But it might be a more complex question than that.
Yeah, of course. Got it. Thank you.
Yeah, yeah, yeah. Okay,
I have a couple
great.
others. Dr. Pavlova, did you
Yes,
want to wait or do you want me to ask?
I can go through.
Okay,
Yeah, I can.
perfect. Is sleep apnea a seizure trigger?
The short answer is yes. And I did not include the slide for this, but um, I have had patients who would specifically have seizures when they don't use their treatment machine. And there are a couple of ways that it can do this, but the major one for a specific seizure, for the triggering of one individual seizure, can be that when there is not enough oxygen or too much dioxide, when you're struggling to breathe, um, and you wake up because of it, that by itself is a trigger of a seizure. Um, on a more global, long-term level, the intermittently lower oxygen tends to be detrimental for many things, including the blood vessel wall. And in that way, it actually can predispose towards things like small strokes, sometimes that the patients might not even be aware of. And it can also be predisposed towards heart attacks. So the long-term effect of it is also there. But yes,
Very good.
And I did not include this slide, but sleep apnea also may be a little more challenging to treat in patients with epilepsy. So this is an area where there should be a lot more advocacy, because insurance companies often would say if the patient within the first period of time doesn't use the machine for more than 4 hours per night, they're non-compliant and they are not never going to use it. But it actually that's not true for the patients with epilepsy, because they may have more challenges for many mechanical and other reasons. And and they actually, so I can actually provide it, but we did a study on this specifically, and it seems that sleep apnea treatment is more challenging for patients with epilepsy than patients who have sleep apnea but don't have seizures.
And
It just takes longer to adapt.
exactly. Dr. Pavlova, a question that I have is too, is should a sleep study be a workup that should be part of the epilepsy kind of workup as well? Should a sleep study ever be part of that, like be part of the whole
If there are sleep complaints, yeah, if there are sleep complaints, you have to keep in mind that a sleep study, as it is now clinically, generally is performed to answer specific questions. Is there a sleep disruptor? And the usual sleep disruptor that you will be looking for is sleep apnea. There can be also movements during sleep that can be recorded. Sometimes patients with epilepsy are more prone towards having sleepwalking type behaviors, but those are more like less likely to be captured during a sleep study. Um, but for the evaluation of sleep apnea, it's a common thing. Probably a good third to a half of the patients with epilepsy may have a higher risk of having sleep apnea. And so uh, I wouldn't do it as a standard thing, but I would ask questions and I would have a very low threshold of having it because treatment is important.
We have a slew of other questions. So what I'll do is hold them
Yeah.
and then let you continue so that we can get through
Okay.
some of these slides. And then we can
Okay.
even hold these if you want to till the end so that we can really give you that time to answer a lot of
Okay.
these questions.
So I'll go a little bit about circadian disorders. What are circadian disorders? The thinking is that the problem is the timing of sleep. And how do you basically not having a mismatch between the biological night of someone and the time when the sleep opportunity is. So if you presume that this patient whom we discussed has to wake up at 5 in the morning, then he would be sleeping between 9 p.m. and 5 in the morning, and you can call it typical for that type of behavior. But this patient would, his current sleep timing is later, and in the extreme form, this would be called delayed sleep-wake phase disorder, someone who has a later biological night and has difficulty shifting it earlier. And this patient, even in the absence of epilepsy, would present with one of the two problems, either complaints that they can't fall asleep when they need to, but also very frequently by being unable to wake up on time for school or work, whatever bothers them most. The converse is someone who has advanced sleep-wake phase disorder, and who will not be able to attend this lecture because they're already sleepy or already asleep at the dinner table. But then they would wake up in the middle of the night and not be able to fall asleep because their biological night is earlier. And I'm not going to go very much through the other ones, but non-24-hour disorder is when you cannot synchronize. And typically this is seen in blind people because they can't synchronize the time. And then there is irregular sleep-wake phase disorder, which is usually which is actually more frequently seen in patients who are older and in the conjunction with neurodegenerative conditions. So he seemed to have difficulty. Okay. I seem to have difficulty moving the cursor. But so how do we evaluate these patients? We obtain a sleep log that tells us when they tell us when they are sleeping, and mark it on a graph. We can use various wearables to determine the sleep activity pattern. And we can also measure melatonin. And melatonin can be measured actually in several different ways, in plasma, in urine, as well as in saliva, which is actually the most convenient method for the clinical use. And the reason why these measurements are helpful is that we want to have a sense of when the biological night of the patient is. Because the interventions depend on their timing. And the thinking is that there is this anchor, if you will, this axis that correspond to the core body temperature minimum, but it's also the middle of the melatonin secretion for an individual. And if light is given before that core body temperature minimum, it will push down the sleep phase of the biological cycle. So if, for example, I'm traveling to LA for a conference, I would be exposing myself to light in the evening hours, and that would push down my biological night, and I would be sleeping at LA time. And then when coming back to Boston, I would be giving myself light in the morning after my biological uh, midnight, and that would advance my biological night. What sometimes happens is patients who have who are trying to attempt a very dramatic shift. They, instead of doing this, giving themselves light after the middle of their biological night, they are doing this. They are giving themselves light so early, and it's not uncommon. People would have multiple alarms to make themselves wake up so early that they actually, instead of advancing their biological night, they're making it later. And so, for example, our patient who now goes to bed, like sleeps between 1 in the morning and 9 in the morning, if this person has to wake up at 5 in the morning, that's 4 hours before their current awakening. And so if he risks actually giving himself light and stimulation before their biological midnight. So it's important to measure exactly where to give the different interventions. So we use this is an example of a sleep log, marking, shading the area when the patient is asleep. We can use, we can measure sleep activity patterns. These are various devices, and it's not a complete list, but there are various things that can be used for this, and they are mostly wrist-worn, have different algorithms of determining sleep and activity patterns, but the principle is the same. Is the more activity signals that the patient is awake, likely, and less activity signals likely sleep. And the patient also can mark when they are attempting to sleep. So this is one example of the output. This is a fancy one that also gives us the color of the light that they are exposed to. But the blue markings indicate when the patient has been given himself a sleep opportunity. We can also measure melatonin secretion. That is when the person secretes their own melatonin, when the melatonin is starting, and it's called dim light melatonin onset time. As the name implies, it needs to be collected in dim light. And literally, the patient spits in a cup and then sends it to we use actually a specific measuring agency for analysis. And what we do see is that, what we're looking for is the time when there is a sharp rise in the melatonin secretion. In this case, this is a patient, as you see, where melatonin is near zero during the biological day, which is normal. This is exactly how it should be. And then it raises at this particular time. This is someone who was actually prone towards early sleep. So this is consistent with their biological night according to their typical sleep times. This is a patient who actually presented with complaints of sleeping very late. She was an engineer, and she just couldn't function during the daytime. She was performing most of her cognitive tasks during the night. And what you see is actually a summation of her activity pattern. And you see a lot of activity in these hours, like the more black means more activity. So the activity starts somewhere between 12 and 3, so 1:30 p.m. And this is when she's most active. And then she becomes inactive after 6 in the morning. So this is when her sleep times were. The same patient, we measured melatonin, and the time when she started secreting melatonin was around 1 in the morning. So this is someone who has a very typical delayed sleep-wake phase disorder. So our treatment protocols for circadian rhythm disorders start really with a good patient education, kind of explaining what are biological rhythms, and then establishing the goal of when this person has to wake up. For example, if a person has to wake up at a specific time, let's say our example with the patient who is thinking that he probably will have to wake up at 5 in the morning, we say, okay, you have to wake up at 5 in the morning. Let's count backwards. You need 8 hours of sleep. So you have to be awake. You have to be asleep at 9 p.m. in order to have a sufficient amount of sleep. And then we tell the patient, and this is based on a protocol that has been tested. We tell the patient you can have melatonin, a small amount of melatonin. We use 0.5 milligram 1 hour before that time when you would have to be asleep in order to wake up sufficiently rested, to have a sufficient amount of time for rest. And this is the so-called, this actually has been tested in a protocol by Dr. Rajaratnam. The citation is here. But this is basically how we would approach patients in whom we are trying to move the biological night earlier. If this doesn't work, we do consider also light exposure, and there are commercially available light boxes that can be used after awakening. It is determined that blue and green light exposure is more powerful. So if there is the possibility of having a light box, using a blue light exposure for 20 minutes upon awakening. If the patient cannot afford it, we use just bright light. And there can be also specific glasses that can be used to change timing. Conversely, if someone has difficulty with the evenings, that is, falls asleep too early, then we established when the required wake time is and when the desired bedtime is. And we would encourage bright light 1 hour before the time when they secrete melatonin. And then if we can't succeed with that, we work a little bit more with blue or green light, and we might also use medications. So within the first 2 years of the circadian clinic, we saw 220 patients. The majority of them actually came for delayed sleep-wake phase disorder. And they most of them actually had some improvement with these measures. And the most probably striking things was the amount of medications that they came with, that were all medications to promote sleep. Fortunately, I see that the individual names are not very well seen, but many of them were taking, more than half of them were taking some medication to help fall asleep. So more than like 60% were taking at least one medication, and almost a third were taking 2 or more medications to help fall asleep. Kind of as a summary, patients with circadian disorders can complain of either hypersomnolence or sleepiness or difficulty falling asleep. We use evaluation with sleep logs, any wrist worn or other objective measures. And if feasible, we measure dim light melatonin onset time with testing saliva. Then we decide on the treatment, determine the goals together, use, in the cases of delayed sleep phase, trying to make the sleep phase earlier, we use melatonin to try and pull the sleep phase earlier, and we use blue or bright light to try and enforce the wakefulness timing. So this is my sunset, and I'm going to start taking questions again.
Yes, we have a lot, and I'll start right
Okay.
when we had. Let's see.
I'm opening the chat.
The pineal gland.
Sorry?
How does phone usage affect the pineal gland?
So I guess you must be referring to use of electronics and the light emitting devices from the electronics. Light suppresses melatonin. And it matters, however, how intense it is and how close to the eye it is, and also what is the color of the light. And so you have heard the standard recommendation: don't use the electronics within, an hour of bedtime. It is a great recommendation, but whether it's realistic, it's another story. I would say that it is good to be cognizant of it and to modify it as much as you can. There is a dark mode that can be used on most phones nowadays. And there is also kind of a dimmer, as well as a way to change the light color on the phone as well. They're not ideal, but they are at least partial improvement methods to decrease the amount of light exposure. The other thing you have to consider also with phones, checking email, a lot of stimulation, and just exposure to a lot of external, potentially worrisome stimuli, is that these things can cause anxiety. And it's not always, so I have had a lot of patients who would say, oh, I just watch the news in bed before I fall asleep. Well, the news is designed to actually make you a little anxious and engaged. um, and unless you're switching to an app that specifically gives you the good news, uh, it can actually makes you anxious, and it's even worse anxiety because most of the time you can't do anything in the after hours uh, except get angry. So keep that in mind. Um, the other things are commercials, which are often like louder and also disturbing and so forth. So all of these things, it's common sense. They can actually affect the ability to fall asleep, potentially having nightmares. So um, those are, but in terms of the circadian rhythms, those are the metrics, the methods to make it less intense to do this.
Yeah.
Um,
There's another question too. Is there any increased sleep disruption with persons who have epilepsy and autism?
oh yes, it's a whole area of so patients with epilepsy have a lot of insomnia. Patients with autism have their own actually a much higher frequency of insomnia as well, and also circadian disruption. Um, and it's an active area of research. It's not clear exactly what is the reason, but it might have to do with social engagement and potentially sometimes depending on how the social functioning is, they may have to do with just being able to sustain these hours. Um, but yes, it's a very common situation. I see something like hypnogram, the structure of sleep, which is generally composed of ultradian. Not sure exactly what the question is. It's a hypnogram is the graphic representation of the different sleep stages. Um, and if it's helpful, I can go back to it, but it's just a graphic representation of the different sleep stages.
Wonderful. I have another question by Lauren Quinn. She said, are seizures during sleep noticeable? My child had absent seizures, but recently had 2 grand mal seizures. I'm still not sure what to look for.
Um, they can be, or they can be just subtle and only visible on an EEG, on an electroencephalogram, the test that uh, involves placing electrodes on the head. The convulsions that happen at night are particularly worrisome because they can be associated with higher rate of SUDEP. So they can be particularly worrisome. Um, are you using a device that to help alert you and potentially turn the patient to the side so they don't aspirate?
Lauren, you can unmute yourself if you'd like to.
Yeah.
Hi, can you hear me?
Hello? Yes.
Hey, thanks so much for answering my
Nice to meet
question.
you.
Nice to meet you too. We actually have a an appointment at the end of February with a neurologist at Boston Children's. So I haven't I'm just starting to kind of do my own research, mom research into like a wearable
Yes.
device. I feel like that will help me feel better. I mean, I have a baby monitor for her, but obviously that's kind of like a false sense of security because only if I'm staring at her would I even know.
Yeah.
Yeah.
Yeah, so so convulsions are the ones that are the most dangerous.
Mm.
And particularly after the convulsion, especially if they make sure that the patient is not on their face because
Okay.
that can be extremely dangerous.
Right.
Um, and ideally on the side is like if they have like it prevents aspiration. But
Right.
yeah.
Yeah.
I'm going to put in the chat for everybody. a PDF that kind of goes over the different seizure alert devices. And then to everybody that is here today, you know, Dr. Pavlova spoke about some, you know, sleep and how important it is. And obviously, you know, our loved ones or ourselves that have epilepsy, sleep, we know is important and also can also be a time that could be dangerous to somebody with epilepsy, like Dr. Pavlova talked about. So I'm also going to include in an email to all of you after our form that you guys can fill out and get connected to one of our CHWs that help our families. And we often help either sponsor or somehow, some way will make sure that if you're interested in getting a seizure alert device, specifically if your seizures have movement to them. So we're talking about obviously seizures like tonic-clonics, and then any type of generalized, and that's piece. The monitors will help pick up that movement and then alert your loved one to that. So, you know, talking to who we were just talking to now, Lauren, it will help alert you in your room. I know my daughter has epilepsy, and for a long time, we used a monitor that kind of made a sound, an alarm in our room if she were to have a seizure. So, and that's called the CME monitor. So I've included a document at the bottom for everybody. So please, you know, you can open it, look at it, goes over the different type of monitors. And like I said, I'll also include a link in the email after so that if you are interested in hopefully getting one of these, and because they can be quite expensive, we're happy to help find ways to get that covered so that if it is something that your family can't afford, we want to make sure that your loved one or yourself is safe. So we are happy to help get you connected and get that as well. So I just want to let you know.
Thank you so much. I really appreciate that information.
You're welcome, Lauren. And we also have seizure first aid trainings every month. So if your family is interested in a seizure first aid training, we can even even do a personal seizure first aid training for your family.
Yeah, that would be great.
So we'll get you connected and get you, but we're here to support you.
Thank you so much. I really appreciate all that. Thank you.
You're welcome. You're so very
Yeah.
welcome.
And actually, one thing to add is at your appointment, you might raise the issue of the timing of the different doses of medications. So specifically for nocturnal seizures, sometimes giving higher dose in the evening can be particularly helpful.
Okay.
Now, the larger proportion of the dose to be with the nighttime dose, but it's something that you should be discussing with your neurologist, but it's one of the methods that can be considered that has been found helpful in reducing the frequency of seizures. This also relates to the other question about nocturnal seizures.
Jennifer Cassidy also asked, napping is good if you're recovering from
Yeah.
people with epilepsy need more sleep. Not only question. So these are questions. Is napping good if you're recovering from a seizure? Or have people with epilepsy
So this is actually an important question for which unfortunately we don't have a great answer, great scientific answer. But it's very common for people to feel very tired after a seizure, and at the same time you will see that the standard good sleep recommendations say don't take naps late in the day, and so forth. My take is it's better to take a nap, that particularly a planned nap is much better than an unplanned nap. And to prevent a nap, a lot of people use caffeine and so forth. So this is more detrimental than just the nap itself. So I would say go ahead. In general, napping in isolation is not something that is hugely terrible. It's just what it can do is it can make the patient go to sleep later on the night after they have had a nap during the daytime, particularly if it's late during the day. But it's a lesser evil than sleep deprivation or something else. And I had actually omitted this, but there is a technique called cognitive behavioral therapy, which is recommended as the first line treatment for patients with insomnia who don't have epilepsy. Um, and often when seeing someone with epilepsy, people will say, well, why don't you try cognitive behavioral therapy? Well, the problem with that particular method is even though it does not have medications, it's all behavioral, it actually involves the potential for sleep loss. In fact, it's embedded in it. And we don't have a modification specifically for patients with seizures. I had asked that we can try and develop a protocol for this for patients with epilepsy because we want to avoid the sleep deprivation, right? We don't want to base on it, but hasn't happened yet. But I would say better to nap than to lose sleep.
And then there was another question about time zones. So it says, how can we travel across time zones, such as from the US to Europe, while minimizing disruption to our circadian rhythm and avoid sleep deprivation, one of the most common seizure triggers? Would taking melatonin be advisable?
Yes, actually, so that is one situation where you can shift your biological night earlier by taking melatonin. And again, so the physiological dose of melatonin is 0.5 mg. Um, and it can be taken. There are a couple of different approaches, but one of the approaches could be to have a smaller shift earlier if that's feasible, and to do it before the trip. The other one could be after already at the new place to just have a smaller, or sometimes it can be even larger shift, but depending on where you are, it would be a shift to like either 5 hours earlier or sometimes 6 or 7 hours earlier, depending on where in Europe it is. Um, but yes, using melatonin usually an hour before the desired sleep onset time, and then making sure that there's plenty of light exposure after awakening.
Another question was, I'm the opposite. I have epilepsy and use a CPAP, and I'm still a heavy sleeper. I believe it may be due to my medications. Is it an issue sleeping for more than 10 hours, like on weekends?
Very good question. And again, um, uh, uh, it is better actually to sleep longer than to be sleep deprived. I know that you probably are referring to some of the research showing that long sleep is probably associated with more disease, and there was one study in which they were showing higher, you know, higher mortality at the extreme ends of the sleep length. However, um, you most people don't cannot oversleep. Like that's our current thinking is that you can overeat, you can store the extra energy for the future, but there is no possibility, to our understanding, there is no current way of storing sleep for the future. So if you're asleep, usually there is a reason for it. And yes, um, most anti-seizure medications have some sedating effect. And then there is another thing is that sleep apnea itself presents with sleepiness, and that sleepiness is not always gone after, even with full CPAP use. In fact, even in the absence of seizures, there are specific wake promoting medications for those patients who have sleep apnea, have used CPAP, and still are sleepy during the daytime. So there is a reason for it. So you probably have two reasons for being sleepy. But allowing a sufficient amount of sleep is good. Even in people who are perfectly healthy, there is a range of the sleep need. It varies actually between 7 and 9 hours. And that is in healthy people who are put in a lab where they don't know what time it is, and they are just like allowed to sleep as much as they can. So even in the absence of drugs, the something you might consider doing is making sure that you don't have silent seizures that no one knows about, because they could be disrupting sleep and be the reason for sleeping longer. And that is usually the reason to do a sleep study with and the sleep study would have to be done in the laboratory, ideally with extra electrodes that evaluate for any seizures that you might not be aware of. There is a question. An at-home sleep study usually involves sensors that detect breathing through your nose and mouth and movement of the breathing-related muscles in your chest. Heart rate is also monitored.
Someone was asking what it was, like what it looks like at home, and I was
Okay.
posting
Yeah.
some of it of what it was, because someone asked a great question. They said, "What's the difference between an EEG and a sleep study?"
Oh, did you answer it?
I did, but if you want to, you're more than welcome to. You
Yeah.
probably will answer it way better than I did. So
Yeah,
you are more
no,
than
it's
welcome.
you probably did. You probably did. During a standard EEG that is performed for the purpose of epilepsy, we are looking for areas of the brain that could be causing the seizures, the abnormal areas of the brain. During a normal sleep study, um, mostly we assume that the EEG is normal, and we are generally interested in what is the state of the patient, whether they are asleep, awake, and what stage of sleep they are. So the standard sleep study involves an EEG, but that EEG has fewer electrodes, and again, they are mostly there to determine what is the sleep, what stage of sleep the patient is in. They can detect some seizures, but the seizures have to involve a large enough area of the brain to be detected by those fewer electrodes. When we try to evaluate for nighttime seizures, there are a couple of ways to do that. One is that I sometimes would ask the technicians to add extra electrodes. It's available in many laboratories. Unfortunately, it's not a separate, it's not always mechanically possible to do, and it might not be because it's not reimbursed by insurance, and many of the sleep specialists are not neurologists. Actually, the majority are not neurologists. They might not feel very comfortable in looking at these studies. The other way is the so-called ambulatory outpatient EEG. The electrodes are placed, they record for, let's say, 3 days, 2 or 3 days, and they capture sleep, but those are not sleep studies. They don't evaluate for things like sleep apnea, but they can capture any unwitnessed or invisible seizures, if you will. We call them subclinical, but seizures that are not easily detectable by others.
Wonderful. We have
My
one
husband had a
question.
sleep study and learned he stopped breathing 125 times per night. Oh, yes. Oh, yes.
Yes.
Unfortunately, yeah.
We have one last question. Should we avoid sleeping with night lights? Does it matter how dark the bedroom should be? It's a great question.
So it's best if it's dark. On the other hand, it is better to have a night light if you're going to get up and get to the bathroom. It is better to be safe. If it's less than candlelight level, like not very dark night light, it's probably not, the effect on circadian rhythms is not major.
Wonderful. And there's also, so we'll take our last question because we're at 8:02 when we wanted to be
Okay.
appreciative of of Dr. Pavlova's time. The last question is there an ideal temperature for sleeping?
A comfortable one.
It's a great one.
I will not give you degrees. So our own body temperature actually tends to fall during our biological night. Our brain and head temperature tends to actually fall as well. And maybe a little bit so passive cooling can potentially promote sleep. However, we are not lizards. Our body temperature has its own homeostatic control. So most of the time, there is relatively, it will readjust itself. You should not shiver. You should not get runny nose. And you should also, it's better not to be sweating too much. So the comfortable zone would be yours, and bodies adapt when you travel to, like, for example, people who have lived in let's say Florida, they tell me that they no longer are as adaptable to the cold temperatures of Boston, for example. So it's our bodies change within the same individual.
Wonderful. Well, Dr. Pavlova, we are so appreciative of your time tonight. And I know that with all of the amazing questions that people asked, they're very interested. And we can't thank you enough for spending your time with us tonight and sharing your information about the circadian rhythm and epilepsy and sleep and all of those pieces. So we are so grateful for you being here with us tonight.
The pleasure is all mine. Many thanks for having me.
Awesome. Thank you. I will send this recording to everybody. You will get an email tomorrow with the recording and also a follow-up survey from our webinar. Again, your input is so critically important to what we do. We want to know what you think so we can make sure we're doing the right and kind of hitting everything on the head with our webinars. So thank you again for everybody being here tonight. And again, thank you, Dr. Pavlova, and everybody have a wonderful evening.
Thank you very much. Have a good one.